So I will be presenting on supracoidal buckling. As we all know that scleral buckling is a dying art and PPV is not.
It's not a dying art. Yes, don't say it is a dying art. Anyway, go ahead.
We are trying to revive, sir. And PPV is, I withdraw my words, and PPV is not always the answer. And there are some things which are associated with the buckling, like extensive peritomy. And then we have the usual exoplant related complications, which have been illustrated by my learned speakers. And then there are suture related complications. And one thing that I am very concerned about is the post-operative astigmatism and limitation to approach of the posterior breaks. So what we can bypass all these and still enjoy all the advantages of buckling. So here comes the role of supracoidal buckling. So we all know the supracoidal space is a potential space of 75 micron between the choroid and the sclera, and it can expand and accommodate up to 200. It can expand up to 100 to 200 microns. And running across this space are thin pigmented lamella that stretch from the superficial layer of choroid backwards and outwards to blend with the lamina fusca of the sclera, which can be separated easily. A space is traversed by the ciliary nerves and vessels. And if you look on the histology, this is the supracoidal space, and this is a video by which won the Red Club Best in Show Award in ESRS by Flavio and colleagues, and in which they passed an endoscope into the supracoidal space, and where you can see the superiorly is the choroid and bridging it is the vertex brain, and previously it was the ciliary nerves. So basically, if we can, it's a potential space where we can use it for our advantage. The potential current uses of supracoidal space is in supracoidal buckling and supracoidal drug delivery like triamcinolone acetoinoid, anti-VEGFs, and implants and targeted chemotherapy, stem cells and gene therapy, and it can act as an access route to the subretinal space. Today we'll be discussing on peripheral buckling through supracoidal route. As we all know, this supracoidal buckling was pioneered by Ahab and Rice and colleagues. What are the things that you require for supracoidal buckling? So basically you need an olive-tipped cannula. You read a Sandler lighting to eliminate and demarcate the break. And you also need fillers. These are mainly derma fillers. And you can also use Halon GV, which can stay there in the supracoidal space for 15 to 3 months as and when required. And they can act as an indenter. So the sclera remains at its place. The choroid is lifted up by these fillers, and this indents and opposes the retina till the permanent chorioretinal scar is formed by the cryoplexy. The surgical steps are usual. First of all, we establish a Sandler illumination. We localize the break with a wide-angle viewing system and peripheral indentation. We do a localized peritomy around 2 to 3 clock hours in the suspected area of break. We do a fine localization of break by a cryo. We establish access to the supracoidal space in the meridian of break 4 mm from the limbus through scleral cut down. And SRF drainage is done to prevent inadvertent IOP rise during the supracoidal injection of fillers. We transfer the supracoidal space with the olive-tipped cannula. We determine the tip of cannula by slightly indenting the choroid while viewing through the Sandler illumination, and inject around 0.3 to 0.4 ml of filler in the supracoidal space. Since both our hands are engaged, so we generally ask an assistant to carefully inject and slowly inject. This will create a mound of sufficient indentation and maximum diameter around 10 to 15 disc diopters. And withdrawal of olive tip cannula should be done very carefully. And then we close the scleral cut down with spectral sutures, and then we close the peritomy. So this is a case of post-traumatic retinal detachment. In this patient, we had 2 atrophic holes in the superotemporal area. Here we can see through Sandler illumination, I am using a ReSight system. And after that, we have localized the break. We do a cryo to determine exact position of the break and whether we are at the right place. Once we have determined the break, we do a marking, and we again reconfirm it by doing a double cryo. So we are now 100% sure that our marking is exactly at the position of the break. We do a peripheral indentation to look for any missed breaks, how that has to be performed before taking up the patient for surgery. Now, in the meridian that is parallel to the break, we do a scleral cut down. You use liberal diathermy to invert the two lasers. And at the point of, we do a external SRF. I think the video got, now this step is very important because we have to introduce some external, and we have to introduce the fillers into the supracoidal space. So here, this is the most tricky position because it's very difficult to determine where the tip of olive cannula is. And once we have determined it, we inject the around 0.3 to 0.4 ml of the filler into the space. And then we close it by the space by the scleral cut down by 80 Vicus sutures, and the peritomy is then closed. This is the day one post-op of this patient. Here a total RD. On the right side of the fundus diagram, you can see the indentation of the fillers and creating a mound, which has led to the closure of the hole and resolution of the detachment. Now, the another use of this is, which I feel, is that many times we take up a patient for surgery, and sometimes we see there is a small hole during the pars plana vitrectomy. So we can use this also for providing a temporary indentation in the inferior retina if it is required for around 2 to 3 months till our chorioretinal scarring is formed. So this was a patient of macular hole with total RD, and this, we can see the peripheral indentation, and it lasted around 60 to 80 days. Now, it's not that it's always, it has some associated potential complications also. Now, this is a case that I did first. This is my first case, and I wanted to play very safe. And this was a case in which I was trying to know how do you go. I just wanted to get a feel of it. So this was a case in which already the vitrectomy was done, and I wanted to know how this olive tip cannula goes inside. So it was basically a safe play that I wanted to do. Now, see how it can, it can see in this case, if you look at there are two humps that are created. So the first hump was created because I was not able to determine only where my olive tip cannula is. And in the second attempt, I was able to rightly place where I wanted to place the fillers in the supracoidal space. So I think it was also the initial learning curve, as well as that the visualization under the silicone oil might be deceptive. Now, this is another case of almost the same post-traumatic superior temporal RD. Now, what happened in this case was that there was an inadvertent increased amount of supracoidal filler that was injected, and you can see that the arterial pulsation stopped for some time, and then there was a certain gust that I felt that I could feel that the vitreous, there is a certain movement in the vitreous, and when I withdraw, I found that there was a chorioretinal incarceration in the scleral cut down, because that is the weakest point of the whole globe, and that is why once you increase the IOP too much, there will be with chorioretinal incarceration into it, and then we had to finish. We had to convert into a pars plana vitrectomy. What are the advantages? That it can be customized buckle according to the need. It can be done in contraindications to episcleral buckling like thin sclera. We avoid extensive peritomy. We avoid exoplant-related complications, suture-related complications, post-operative astigmatism, and limitation to approach to posterior breaks. There are certain cons that it has certainly a high learning curve than the usual buckling that we do. And long-term indentation is a question mark. So we basically, after 2 to 3 months, you go on chorioretinal scar strength that is able to determine what is the success of the surgery. Thank you.